Welcome to the Speaking of Women's Health podcast. I'm your host, Dr. Holly Thacker, and I am back in the Sunflower House for a podcast with a very special guest. I am talked about her several times on my previous podcast saying, oh, you have to listen to Dr. Gubbels and the one on chronic pelvic pain. And unfortunately, it was one of the podcasts that got eaten up in the interwebs. And so we are re-recording, but this is definitely worth your wait, listeners. So thanks for joining us. I'm your host, Dr. Holly Thacker, the Executive Director of Speaking of Women's Health. And we're going to dive into a topic that unfortunately affects millions of women, but is so misunderstood. Sometimes it's overlooked. Sometimes it's misdiagnosed. It's chronic pelvic pain. CPP is what we use in the medical chart. Joining me today is Dr. Ashley Gubbels. She is a leading expert in minimally invasive gynecologic surgery and pelvic pain management. In fact, she's internationally known and travels all around the world to discuss this, present research, and interact with leading experts. So we're so fortunate to have her. She's a board-certified OB-GYN. She's fellowship trained in gynecologic surgery, and her practice is very specialized and focused. She has special interests and expertise in pudendal neuralgia and other pelvic neuropathies. Before she joined us at the Cleveland Clinic, she served in the United States Air Force as a general OB-GYN and the medical director of 99MDG Women's Health Clinic. Dr. Gubbels is also the mother of a beautiful 3.5-year-old girl named Emerson. And as some of my listeners know, I have a son named Emerson. So a little bit of difference in the spelling. Welcome, Dr. Gubbels. We're so happy to have you here.
Thank you for having me. Appreciate it.
And so why don't we just start first with the basics? Tell us what chronic pelvic pain is in women and how it's different than the occasional discomfort that we all get with cramps and other pelvic symptoms.
Yeah, so chronic pelvic pain has had varying definitions over time and is now defined as pain in the pelvis that's not responsive to typical therapies. So, maybe that is excision of endometriosis, but continued pain that persists beyond those typical treatments. It's usually, at least something that's lasting 6 months in duration, and has to have impact on someone's life. So causing functional impacts.
And I was surprised when I started to delve into this topic because I had a loved one that I thought had pudendal neuralgia, but it's not. It's actually of a spine. And I was really delving into this field thinking, I didn't seem to be very well trained in this area. I always knew that we had a special clinic that had lots of different subspecialists dealing with it. But reading about this condition in women, I was shocked to find out how many women post-delivery, postpartum, post-trauma, post-surgery have chronic pelvic pain.
Yeah, it's quoted anywhere from 15 to 25% of women over the course of their lifetime. So of course, depending on the specific condition that we're talking about, that's either more or less endometriosis kind of being the most common cause for chronic pelvic pain, affecting about 1 in 10, although that might be even an underestimate, versus pudendal neuralgia being more along the lines of 1 in 100,000. But again, that's also probably underestimated because, like you said, so many of us are really, as gynecologists and urologists, et cetera, not really trained in these conditions. People definitely are learning more, over time, but it's still very unrecognized. And I think often physicians don't really know what to do. And so sometimes it's just kind of you're still healing, it'll be fine, it will go away, and it doesn't. And so really making sure that we're getting people trained and knowledgeable, at least so they've heard of the condition so that they can, research and help get patients either connected to someone or expand their own skill set.
Mm-hmm. And I've just been fascinated in several different realms in medicine where there's just overlap between different specialties and we all have our own approach. And I think that's one reason I connected with you, because you're someone who took a lot of different interest and expertise in different areas to bring it together. And I think for some of these difficult conditions that patients can go from doctor to doctor, they kind of need that. Tell us your story about what you were interested in when you were in medical school and kind of how you came to this field, because I think it's very reflective of a very interesting background.
Yeah, so when I wanted to go to med school, I always thought I was going to be an OB-GYN. I wanted to deliver babies and all of that. And through med school, sort of our initial classroom work, the first thing that our school did was went through neurology, which I found fascinating and thought you would always be on that cutting edge, and then arranged my schedule so that I did that as my first clinical rotation. And it was at a rehab facility, and not a lot changes from day to day, and you can tell people exactly where they stroked, but you can't do a lot about it, at least 20 some years ago, although I think that's still kind of the case, unfortunately. And, I thought, okay, well, that's not quite a right fit. And then I did surgery, and I actually fell in love with that a lot more than I was expecting. And then I did OB, and I thought, okay, well, this is a nice mesh of surgery and the obstetric side. And so I went down that pathway. And then while I was a resident, thought about, again, delved into some of the other surgical subspecialties. Minimally invasive GYN surgery, or now the term is complex benign gynecology, didn't really exist much then. The fellowships were just starting, so it wasn't really something I was aware of. And, ultimately decided, okay, I'm going to stay a generalist, go back and do my military payback time, because again, as you mentioned, that's how I paid for med school. And sort of, again, finding patients with pelvic pain in that generalist practice, learned about physical therapy and some of these, muscle agents from a physical therapist who just came to talk to our group, which was a group of 6 physicians on an active duty base, and then decided to go back to fellowship and matched at a program that really focused on chronic pelvic pain. So it was endometriosis, but it was also more than that. It was interstitial cystitis, pudendal neuralgia, myofascial pelvic pain. It really opened my eyes to sort of the breadth of what could be done for women, particularly those that have surgery for endo and don't get better. And my mentor, Michael Hibner, had trained in Nantes, France, with a neurosurgeon who was doing open transgluteal pudendal nerve decompression surgery. And it really, within that first year, sort of meshed that I was like, this is neurology, it's surgery, it's obstetrics. I also really liked psychiatry. Of course, when we've been suffering through pain for so long, that does a number on somebody's psyche, anxiety, depression. And so it was just like a natural fit for me. And it was not a path that I was aware existed, or it didn't exist, honestly. Then it's kind of made my career a bit. And so it's challenging work. It's a lot of sifting through history and really trying to understand symptoms and how they came about, to work your way back to what you think the original culprit is, and then figuring out how do you deconstruct everything that's going on, and then deal with the underlying issue, along with all of the overlay that has happened over time, right? Medical trauma from not being believed, or from people trying to do things that, have made somebody worse. All of that part is really important. And so what we are, growing here is really a multidisciplinary clinic. So I work with our core team as myself, a family medicine physician that has a women's health fellowship, and a nurse practitioner. I work very closely with our pain anesthesiologists, our interventional radiologists for nerve blocks that I'm not trained to provide, and more advanced, like neuromodulation, impacting nerves. We have our minimally invasive GYN surgery team. So there's going to be 6 of us total who are doing surgery for endometriosis and adenomyosis. I'm hoping to get, down the road, even like a 1-year fellowship in chronic pelvic pain, to sort of add on to people who are doing GYN surgery, to understand what other things that we can actually be doing for this patient population. So it's been really rewarding.
That is just so superb. I've heard this phrase, and it's really resonated with me, that pain is universal, but suffering is optional. Mm-hmm. And so that's why I really, commend you for bringing all these resources together. And I think that, it's impossible for one person to know everything. And there's so many other fields. Like I've had physical therapists on our podcast, and it's amazing, they say, well, if it wasn't for surgeons and scarring and fascial problems, we wouldn't be in business, and we're really in business and we know how to deal with this. Mm-hmm. And it's something that I don't remember in my general surgery and OB rotations, ever learning about. Certainly you learned about wound care, but it was very kind of specific and superficial. And so I think that the more that you involve people, just for our listeners, I want to just go over some basic concepts. So tell us a little bit about what endometriosis is and adenomyosis and these common pelvic diseases in women's pelvis.
Yeah, so endometriosis is where tissue and cells that are what should be lining inside of the uterus are out into the abdomen. They're growing on lots of different structures, and they don't know that they're in the wrong spot. Now, we don't know exactly, is it identical to what's the uterine lining? We don't know how it gets there. We know it has some hormonal response to it, but it can also create its own hormones, and so it's a particularly challenging disease. Like I mentioned, it grows most often in the pelvis. It can grow into the bowel, the appendix. It can also grow up into the diaphragm. There's cases in the lung, brain, lots of other weird random places that we really don't understand how it's getting there. But the vast majority being in the pelvis, and it activates nerve endings, which is how our body senses pain. Pain is an electrical signal that travels through a nerve up into the brain where it's perceived. And so you can get inflammation around the nerves, you can get fibrosis or scar tissue around the nerves, you get the hormonal fluctuations that are over time, essentially, if you have a menstrual cycle every month, you're getting this repeating every single month. And our body, unfortunately, gets better at things, right? We get better at writing as we do more of that as children. We get better at surgery the longer you do it, and our body gets better at pain signals the longer and the more often it's exposed to them. And so it's sort of this idea of the nerves that wire together, fire together, and so you can have the whole nervous system really ramping up. And even with adequate excision of disease, some people do not get relief. I would say the most do, but it's not just surgery that they need to really manage that. Adenomyosis on the flip side is the similar cells, but they're inside the wall of the uterus. They're in the muscle of the uterus. And so again, if they kind of respond to the hormones and there's, microscopic bleeding, there's nowhere for that blood to go. That creates inflammation, that creates uterine irritability, creates more cramping, contributes to heavy menstrual cycles. And these things really end up to be quite debilitating for women. And, as you mentioned, pain is universal, suffering is not. It's also an impact on everyone's individual nervous system. So are you somebody who, your nervous system is a little bit more sensitive? What's your past exposures in terms of, how depressed might you get from pain? All of those things really layer on and create a very different, you can take almost the same pelvis and have people experience that very differently, which is what makes the challenge in treating these patients, because you do have to very much individualize care.
That's excellent. And certainly from a basic women's health perspective, menstrual cramps can be primary or secondary. And I think the average OB-GYN or primary care doctor can address that, certainly stopping ovulation and cycling if someone's not trying to become pregnant can be helpful, and also maybe preserve fertility. Do you see fibroids, which are muscle overgrowth of the uterus, which up to, it seems like 80% of women have? Do you see that involved in pain, or is it mainly the adeno, central and peripheral nervous system?
Yeah, it's more so that. You definitely can have fibroids in terms of, large, causing just pressure symptoms. You can have people who have degenerating fibroids where it's sort of outgrown its blood supply, and it's almost like the fibroid's having a heart attack. So pain related from that standpoint that can be contributors. I'd say, in general, most fibroids are probably not necessarily causing chronic pelvic pain in the sense that we think about, but they can be certainly mixed in. So we have people that have fibroids and they have endometriosis, and those cases are always a challenge because for whatever reason they tend to bleed more and things from that standpoint, something that the interplay between those two conditions. creates.
And you have been listening to the Speaking of Women's Health podcast. I'm your host, Dr. Holly Thacker, in the Sunflower House with minimally invasive surgeon and chronic pelvic pain expert, Dr. Ashley Gubbels. And we're talking about the causes of pelvic pain. Probably in the next podcast, we'll get into some of the treatment options. But as we're still exploring this issue, there's other things, of course, in the pelvis besides the female pelvic organs that we've talked about. Do you want to talk about the bladder and the bowel and interstitial cystitis and irritable bowel syndrome, vulvodynia, that whole perspective and how you tease that out?
Yeah. I think that before we move into those, actually, one of the things I really want to highlight is pelvic floor. So this is really the thing that I think connects a lot of these things. Is our pelvic floor muscles, which are like a bowl of muscles sort of supporting everything internally. So things have to pass out of them, things have to pass into them. And if they're tight and contracted, because, right, if you've been in pain, you're naturally tensing and guarding. And then, that begets more pain if you attempt to have sex. And that's really the biggest challenge, I think, in terms of what we have to treat. We can definitely make impact on a lot of these other conditions, but in terms of what we have available for really pelvic floor, that's where our amazing pelvic floor physical therapists come in and do amazing work with manual release, teaching how to breathe and get those muscles to actually move again, how they're supposed to. And that is one of my goals, is to be the person that figures out, like, how do we actually find an adequate treatment for this condition. So then circling back, right, exactly. There's a lot of other organs in the pelvis. So the bladder can cause pain. It used to be called interstitial cystitis. Now it's bladder pain syndrome, where it's just the sensation that the pain is coming from the bladder. It's a clinical diagnosis, so we don't have specific testing. We, of course, make sure that we rule out UTI. Sometimes that condition can develop, after someone's had a UTI.
Bladder infection.
Bladder infection, exactly. Sorry. And kind of have this, again, nervous system heightens and continues that, sending that pain sensation. Sometimes it's related to sort of allergens and these different cells that exist near nerve endings in the bladder. Again, we're not really sure exactly what caused a lot of these conditions, because they're, historically quite underfunded from a research standpoint. The bowel, again, irritable bowel syndrome, very, very common, high prevalence in our patients with endometriosis, whether or not there's actually disease growing on the bowel. So constipation being really the more significant impactor of the two. Between diarrhea, you have some people that have mixed IBS, so they kind of fluctuate between diarrhea and constipation on their own, and that's really problematic. And so I think where the modern medical system does a disservice to these patients is they go to the gynecologist for their menstrual pain and their period, and they think about their uterus, and they go to the urologist to talk about their bladder, and they go to the GI and maybe colorectal to talk about the bowel, and no one's necessarily looking at how are these things all functioning together, how are we optimizing. Of course, each physician is trying to kind of optimize its own structure, but you can't really do that in isolation, because again, there's so much nervous system overlap in the pelvis with how these organs talk to one another, that they can very much play off of one another and play off the pelvic floor through a nervous system component, as well as just to being next to one another physically. And so I think it's that piece that really is what our program and many of the other professionals throughout the U.S. Are looking at pelvic pain in that way, as we need to have somebody who owns the house, who owns the pelvis. And then, of course, we dip into our colleagues for their expertise. Like, I don't manage, meds for IBS necessarily, but because that would be a large part of my practice. But it's, again, getting somebody looking at how all of these things are working and making sure that we're getting adequate treatment to each of those structures.
Now, tell us a little bit about the nervous system in terms of, and some of the peripheral neuropathies and like vulvodynia. The one thing I've certainly seen in my practice is that when women have vulvodynia, they certainly just seem to be more sensitive in general. And it seems like their nervous system requires a much higher dose of estrogen if they're postmenopausally, locally, to the vagina and vulva area, as well as systemically compared to the average woman. And so I always tell my patients with vulvodynia, if I try to reduce your hormone dose, remind me, we already tried that and you got worse, so we won't do it again.
Yeah, yeah. Yeah, these are challenging as well, again, underfunded. And so there's the question of, is it, there's hormonally mediated, so those that are related to hormones, so sometimes develop when somebody's on long-standing birth control pills because of the estrogen and hypoestrogen, like low estrogen that sort of comes relative in the vaginal tissue. There is thought that there may be some sort of, we call it neuroproliferative disorder, where there's a lot of increased nerve endings in that tissue where it transitions from external vulva to internal vagina. And then the other kind of hat is there something like pudendal neuralgia, where it's really a nerve injury or nerve signaling issue. The pudendal nerve carries all those signals for any of those conditions, but it's trying to figure out, is it the generator for why they're feeling pain in the vulva, or is the skin tissue, et cetera, of the vulva firing the nerve?
So the chicken or the egg?
Always the chicken or the egg. Exactly.
And then what about just the brain and the spinal cord? Because of course that is what's all connected to the pelvis. And how do you help differentiate? I remember you were talking to me, there was like I don't know if it was an AI program or something that you were putting in to say it's more likely to be local pelvis or more likely to be spine.
Yeah. Again, a lot of it becomes down into history. We know that there are absolutely, changes that are happening in the spinal cord and in the brain, kind of that, again, nerves that fire together, wire together, and become like a well-worn path. So anytime anything triggers, it triggers that pathway very easy. It's like a well-worn path in the grass. So it takes a lot to start trying to undo that. And that's where, we're using medications like gabapentin or pregabalin or amitriptyline, some like antidepressants and those types of things that work in that central nervous system to try to dampen the signal, dampen how easily that signal can get transmitted to the brain. Of course, impacts with that is that drugs often have side effects, and that can be challenging to kind of balance around how am I managing your pain but not causing too much side effect. And so, I honestly think far in the future, there are already teams that are looking at functional brain MRIs and mapping where pain sensations are felt. I think way in the future, we're going to mostly be dealing with non-structural pain, so meaning things that, I can't cut out as a surgeon, non-structural pain by stimulating the areas in the brain that are sensing that, because as long as we can interrupt those signal pathways, then we should be able to moderate the pain some.
And is that in part how like TENS units, these external electrical stimulators work? I mean, does that help rewire the pain at a local level?
It may. We don't fully understand, exactly what those are doing, other than I kind of tell people it's the idea of like a gate method. So I'm stimulating the skin that comes into the nervous system at the same area, and that basically, if that is overwhelming the gate, then the other pain signal can't get through. So that's how that's doing that. There is actually, I have an amazing research fellow who's actually hanging out behind me here, who is a urogynecologist and has studied the use of TENS on the posterior tibial nerve, which is something that is done more so with a needle for like overactive bladder, but has looked at that for dysmenorrhea, so painful cramping. And there are a few studies out there that have shown some promise in terms of helping modulate that nervous system by, again, firing the same nerves and interrupting pain signals. And so we're hoping to evaluate that for like our pudendal neuralgia patients in terms of whether that may be a non-invasive way to manage pain.
Fascinating. And going back to bladder pain syndrome, which used to be called interstitial cystitis, in terms of the diagnostic workup, do you usually do cystoscopy or potassium infusions to trigger?
Not anymore. So it used to be when I was a resident, we would backfill people's bladder with potassium chloride, which would cause a significant increase in pain. And if it was a big enough increase, we labeled it that. That has sort of fallen away. It's a little bit of an old torture thing, I think. But it's really, I mean, again, now a diagnosis of exclusion. So we make sure that there's not a UTI, recurrent UTI. We probably should be looking at things and making sure there's not mycoplasma or ureaplasma, which are kind of these atypical bacteria that can be easily overlooked. And then it's, again, working through pelvic floor, nervous system, avoiding potential dietary triggers. So we know that like certain foods, even very healthy foods that get turned to more acidic in the bladder or in the urine, can irritate the bladder more. And so that's one of our first steps is physical therapy and dietary modifications to figure out, are there certain triggers in your diet that are really exacerbating this for you, and kind of a stepwise approach. I don't necessarily do cystoscopy right off the bat. But I am sort of opportunistic about it in terms of if we're also looking for endometriosis, I may, look in the bladder while we're there. Or if we continue to have a lot of symptoms once we are, I feel like we're fairly down the pathway, we'll look. There's a subtype of interstitial cystitis, and really it's probably its own condition, truthfully, is where there are ulcers in the bladder. And that's relatively rare. I've only seen that, honestly, once. In my career, so not common, but those patients respond often pretty well to actually like burning those lesions and ablating the scar. But I think, those patients probably end up often more so going down the urology pathway first. So.
And what about that old-fashioned treatment? You used to see all those ads in the 1970s about DMSO, it's a solvent. It's certainly used in the lab. Is there DMSO installations being done?
We don't do DMSO anymore. We usually will use a combination of lidocaine or a long-acting like local anesthetic, and then heparin. And there are lots of different concoctions out there. So the anesthetic, of course, gives just acute potential improvement in pain. The heparin actually is working as an anti-inflammatory in that bladder lining. And some people do well with those, and some people find they really are triggering to them. So it's kind of a trial and error. There are, definitely people have different concoctions out there. Some people add Toradol into the infusion, et cetera, but there hasn't really been any head-to-head studies looking at is one of these superior or not.
To another.
So, yeah.
And what about the oral drug Elmiron? I've seen some people get some pretty significant relief with that, but then I think there's some warnings regarding retinal problems.
Yeah, so that has been limiting. I historically have not used a lot of that, in that we think it's 50% of people respond to it. You may have to take it for 6 months before you see any symptom relief. It can cause hair loss. It can cause weird tastes in the mouth. And then, of course, yes, the eye changes that they've noticed. And so I usually leave that for much further down the algorithm for that reason. Because it's an expensive drug, and for maybe 50% of people improve. Although I would say, really, when it comes to any of our drugs, it's everybody's genetics are different, and so what one person will respond to, another person won't, and we don't really have testing for that yet to figure out, okay, are you somebody that this is a better drug for, or should I start you on this one? It's still kind of in a little bit of that trial and error process.
And then, of course, we have to remember that placebo is one of the most effective drugs we have, meaning the brain is so powerful. And that's why these randomized controlled, placebo controlled, to know what the response is. And I tell patients, if you have that attitude that you're going to get better, you're more likely to get better, just in general. And I was fascinated by a research trial where they broke people into 3 categories. One person, they measured the strength and exercise and their strength at the end. One, they didn't do any exercise. In the middle one, they said, just think about exercising. And of course, the strongest person is the one who does the exercise, but the intermediate was just thinking about exercising. So when I can't make it to the gym, I just think about the gym.
I think my abs into existence.
So anyway, this has been so fascinating, and we're going to bring you back, and we'll have a second edition talking more in depth about surgery and therapies and other exciting innovations. So thank you for joining us in the Sunflower House. If you enjoyed this podcast, please give us a 5-star rating, share it with friends and family, and we look forward to seeing you back in the Sunflower House. Remember, be strong, be healthy, and be in charge.